What happens to insulin after total pancreatectomy surgery? Imagine losing a vital part of your body that keeps your blood sugar in check. When a person undergoes a total pancreatectomy, the entire pancreas is removed, often due to pancreatic cancer or severe chronic pancreatitis. The pancreas is the only organ that produces insulin, the hormone that helps regulate blood sugar levels. Without it, the body can no longer produce insulin naturally, which leads to a type of diabetes called pancreatogenic diabetes or insulin-dependent diabetes. Because the body no longer makes insulin, patients must rely on external sources to manage their blood sugar. This means they need to take insulin injections or use an insulin pump daily. The goal is to mimic the body's natural insulin releases to keep blood glucose levels stable and prevent dangerous highs or lows. Right after surgery, insulin therapy begins immediately, and it becomes a permanent part of the patient's life. The amount of insulin needed varies from person to person. On average, patients requiring about 0.49 to 0.58 units of insulin per kilogram of body weight each day. Interestingly, this is often lower than what people with type 1 diabetes need. This difference is because after a total pancreatectomy, patients tend to have increased insulin sensitivity, possibly due to changes in digestion and absorption, and the absence of pancreatic hormones like glucagon, which normally helps raise blood sugar when it drops. Insulin therapy after this surgery involves two main types: basal insulin and bolus insulin. Basal insulin provides a steady level of insulin throughout the day and night to keep fasting blood sugar stable. Bolus insulin is taken around mealtimes to manage spikes in blood sugar after eating. The proportion of basal insulin may be lower compared to people with type 1 diabetes because of differences in insulin needs and sensitivity. In some cases, surgeons perform a procedure called Islet autotransplantation during total pancreatectomy. This involves isolating insulin-producing islet cells from the removed pancreas and reimplanting them into the liver. The hope is that these transplanted cells will produce some insulin, potentially reducing or even eliminating the need for external insulin. Over time, some patients may achieve partial or full insulin independence, especially within the first year after surgery. However, many still requiring insulin therapy, and the amount needed depends on how many islet cells survive and function after transplantation. Preoperative factors also influence insulin needs. Patients who already have diabetes or have had it for a long time before surgery often need higher doses afterward because of insulin resistance. Factors like age, body weight, and family history of diabetes can also affect how much insulin a person needs after surgery. Long-term management is essential. Patients must monitor their blood sugar levels regularly and adjust their insulin doses accordingly. This careful balancing act helps prevent both high blood sugar, which can damage organs, and low blood sugar, which can cause dizziness or fainting. Because the pancreas also produces digestive enzymes, its removal means patients need pancreatic enzyme replacement therapy to aid digestion and nutrient absorption. In summary, after a total pancreatectomy, the body stops producing insulin naturally, so patients must depend on external insulin for life. The exact amount varies based on individual health, pre-existing conditions, and whether islet autotransplantation was performed. Managing insulin therapy after this surgery is complex but crucial for maintaining good health and quality of life. Always consult healthcare professionals for personalized treatment plans and ongoing support.